It's Erin at supercoder.com. Today I'm lucky to be talking to Part B Insider editor Torrey Kim. She's in my part of town dropping her dog off at the vet, and she's stopping by my house to tell me about all the challenges coders are having with 2010's new consult coding rules. So what's all this about? I hear about trouble with MSP claims, Torrey.
Medicare's refusal to accept consultation codes is causing a lot of billing headaches in cases where Medicare is the secondary payer, Erin. The problem comes in when the patient's primary insurance wants you to bill for consultations and will pay for them, but Medicare will not.
So there's a roadblock to getting the MSP part of the reimbursement. So what do? How do I get my cash?
That's complicated. According to a recent MedLearn Matters article, you can do one of two things. Your first option is to bill the primary payer an E&M code and then report the amount actually paid by the primary payer along with the same E&M code to Medicare, which will then determine whether a payment is due. Or the second option is bill the primary payer using a consult code if they still accept them, and then report the amount actually paid by the primary payer along with an E&M code that is appropriate for the service to Medicare for determination of whether a payment is due.
Okay, so which option should I choose?
CMS says in the article that option 1 may be easier.
Uh-oh, I hear CMS and easy in the same sentence. I'm nervous.
Yeah, I know. Sources who are looking at the bottom line tell me it's best to decide whether you will get paid better via payment from the primary insurer with a consult code versus the alternative, which is just going ahead and billing E&M codes to both the primary insurer and Medicare, the secondary insurer.
Alrighty then, sounds easy.
Erin, you're so naive. There's another potential snag to getting paid for consults, or what formerly were coded as consults. In MSP situations, in some cases, the doctor may not know whether the patient is on Medicare or has a different insurer when he documents his consultation. For example, if the doctor sees the patient in the hospital, he's not going to know the patient's MSP status. That means it's the coder who will find out the patient has Medicare as a secondary payer. So the coder will have to deduce an appropriate E&M code from the physician's consult documentation.
Wow, sounds really messy.
It is.
While I've got you here, can I answer one more question we've got from a reader?
Sure.
So here's what the reader wants to know. Now that we have these new rules, any physician who sees a patient for the first time during an inpatient admission can now bill an initial hospital care code as long as someone else of the same specialty from their own practice has not already treated the patient during that admission, right?
Right, as long as the correct documentation is all there.
Okay, so say it's a weekend and a patient is admitted by another MD from a different practice. Then, when the week begins, my MD, who is the primary, comes in on Monday and takes over the patient's care. Since it is my MD's first encounter with that patient during that admission, and since he is from a different practice, he can build an initial care code, right?
Correct. The doctor who's considered the attending physician will append modifier AI to his claim to show that he is the attending, and all other physicians who see a patient for the first time in the hospital can build the initial hospital care code. This is a new change that came when Medicare stopped accepting consult codes.
Well, Torrey, thanks so much for consulting with me on consult coding. For more of Torrey's articles on 2010's consult coding chaos, visit supercoder.com. Heroes welcome. All right, we're done. I think the